Right. Well, good afternoon or hello, everyone, and thank you for joining us. We are excited to have you here with us today. We are we're going to be talking about two state-based webinar or two state-based programs. This is the first of a two-part webinar series. We're going to be talking about the Pennsylvania Rural Health Model, as well as the state's advancing all-payer health equity approaches and development model, also known as AHEAD. My name is Candace Talkington, and I am the Manager of Strategic Planning here at the Rural Health Redesign Center. I'm going to be your moderator for today. Very excited to have with us is Janice Walters. She is the Executive Director and Chief Executive Officer of the Rural Health Redesign Center. She is a highly rated rural health expert with over 20 years of leadership and healthcare finance experience. She's also a national leader supporting quality access to healthcare in rural communities across the U.S. Janice has also led the rural-focused technical assistance program initiatives such as the PARHM model, as well as the Rural Emergency Hospital and the Rural Northern Border Region Healthcare Support Program. Before we get started, just a couple housekeeping items. You may notice that you are all on mute. This is just to prevent any inadvertent background noise. Whenever possible, we do encourage you to use the link in your registration rather than just using the audio only portion. This will give you the best possible experience for you. We also want this to be somewhat interactive. Some of you submitted questions through registration, but you may have other questions, so we encourage you to use the Q&A feature. You'll see that either at the bottom of the top of your screen, depending on your layout. Those who may need closed captioning, that is available to you. If you do not see the closed captioning button on your screen, you may need to click on more at the top of your screen and then select your language from there. We will be making the slides and recording available to you within a week after this event. You'll find that on our website at rhrco.org within 1 week after the event. If you have any questions after this and you want to reach out to us, you can reach out to us at rhsupport@rhrco.com. All right, so as I mentioned, this is a two-part series. Today, we're going to focus on a few things. We're going to introduce the Rural Health Redesign Center for those of you who may not be familiar with us or what we do. We'll also provide a high-level overview of each of the PARHM and AHEAD model programs, highlighting similarities and differences across each of the models. In 2 weeks, we're going to do part 2, where we'll dive deeper into what is needed to implement a program like AHEAD or PARHM, and share some of our key lessons learned from our Pennsylvania experience. So just want to share with you a little bit about the Rural Health Redesign Center. Who are we, what we stand for, and what we do if you're not familiar with us. Our mission is to protect and promote access to residents of the Commonwealth, as well as other states, to a high-quality healthcare in rural communities by encouraging innovation and healthcare delivery. And we'll share a little bit more about what that means here in just a second. Our vision is to help rural communities thrive through improved health. We set a standard guiding principles that really drive the work that we do. We are a service organization, and we use that acronym, the SERVIC, because we are an organization that lives to serve those rural communities. We perform our work at the highest degree of excellence, and we respond to all of our partners as quickly as we can. We pride ourselves in reaching out to the best of our ability to get back with you with an answer, or at least response, in 24 to 48 hours. And we put a high value on putting value into our partners' hands. We care a lot about the people with whom we work, and we make sure that what we provide to you is of value. We make a commitment with every single partner that we work with, whether it's a consumer, a hospital, or our community partners, and serving those rural communities. The Rural Health Redesign Center, while we support specific programs, as I mentioned before, such as the PARHM and the REH models, we also offer a whole host of other technical assistance services, including financial analysis, clinical transformation, and value-based transformation support. I won't read all of these to you, but just want to make sure that you all are aware that we have several services. We know that the rural communities may not always have the resources that they need, and we we aim to help serve those rural communities by offering services that are of value to you at the right time. All right, so that's just a high-level overview of Rural Health Redesign Center. Again, if you have any questions or you want more information about any of these services that we've talked about, please feel free to reach out to us. So with that, I'm going to turn it over to Janice, and Janice is going to walk us through our discussion today. As I mentioned before, we do have the Q&A function, so please feel free to type in your question and the answers, and we'll get to those at the end of today's session. So Janice.
Thank you, Candace, and thank you all for being with us today. And really, as Candace has already identified, our goal is to just educate really through a lens of similarities and differences between the Pennsylvania Rural Health Model and the current CMMI opportunity known as AHEAD. Certainly, we've been in this space now for 6 years, a little bit more than 6 years as it relates to planning and implementation. And so certainly we get a lot of questions given this new opportunity. How is it similar? How is it different? And how has our program here in the state of Pennsylvania actually informed this next generation program from CMMI? So certainly as part of some of the framing documents and introductory documents that came out from CMMI, obviously our program was one of the programs identified that informed the AHEAD opportunity. And so really in the spirit of just sharing, learning, and providing education regarding our program, certainly as we've been in this space now for many years, we have had outreach from a lot of different states, a lot of different stakeholders wanting to learn from us. And so thought this format might prove valuable. As Candace has already identified, we do want it to be interactive. There's a lot of content on the slides that I'm going to go through, and we'll move through fairly quickly because I do want to allow time for question and answer. We've tried to hit a lot of this, in our formal content, but certainly understand that we're not probably going to capture all of your questions in the content that we've developed, and really do want to provide that opportunity for just dialogue, again, in the spirit of learning. So Candace, if you move in or move on to the next slide. So really, at the highest level, the Pennsylvania Rural Health Model, just hitting this slide on some key highlights of our program. So it obviously was a state program. It was a voluntary state program. Some of the other demonstration programs out there, such as Maryland, was not voluntary. Ours was, but it was considered a state-based program. And so it was a 7-year program. Certainly there were total cost of care requirements within our agreement. Our program was specifically designed for rural, recognizing that there's rural crisis across the country as we watch more and more hospitals close. CMMI recognized the need to test a rural specific program, and we in the state of Pennsylvania were fortunate enough to be given that opportunity. But it was voluntary and again made available to hospitals that met certain definitions, rural providers in the state, and it obviously had cooperative agreement funding tied to that. Specifically to program goals, one of the overarching goals that we were looking to achieve was provide stability to rural hospitals through alternative payment, and then really support hospitals in transforming from a volume-based delivery system to a value-based delivery system. So at the highest level, they were some of the program goals, also then looking to improve population health, improve access to care, and also specifically focus on decreasing deaths associated with substance use disorder. And then really the role that we played here in the RHRC was leading this work from an implementation perspective, recruiting the hospitals, working with the payers, developing the methodology, developing that global budget methodology, as well as leading the transformation plan effort. So that was really the role that we played here in the RHRC, was really the administration of the program. If you move on to the next slide. So who are we from the RHRC's perspective? We are an entity that was actually created through legislation to lead and govern this work. And so there was a statute passed here in the state of Pennsylvania on November 27th that called for the creation of this entity within 6 months. And so actually the end of May in 2020, right as the pandemic was, starting to be in full force, we actually birthed this organization, the Rural Health Redesign Center, and have continued to manage the program to date. Why was this entity necessary? Really, as we were engaging with payers and hospitals in the state of Pennsylvania, it was really identified that this issue of rural health sustainability was so important that we wanted to make sure that there was an entity specifically for this purpose of advancing this mission that was actually outside the governor's jurisdiction. Our hospitals, as part of the recruitment journey, really felt that an independent entity that had equal representation of stakeholders, predominantly payers and hospitals, that there was an entity created to ensure that stakeholder input was direct into the governance structure. Also, given the significance of this, that it was not necessarily directly tied to a governor's priority. And so really trying to establish an entity that could do this work, and I would say withstand the political environment of elections and all of that goes with a state government. So really this board that was created is actually made up, as we state, of stakeholders. And those stakeholders include prominent Commonwealth agencies such as the Department of Health, the Department of Human Services, as well as our Insurance Commission. We have equal representation of payers and hospitals. So the number of hospitals actually was determined by the number of payer seats that were going to be represented on the board. And then also we wanted to bring in some national experts on rural health and global budgets in particular. Given the newness of this work, felt it was really, really important that we had a national perspective on our work. So all of that was really identified by statute that created us the organization to lead this work within the state of Pennsylvania. And then we actually have a sister organization, a not-for-profit, that actually leads the work outside of the state of Pennsylvania, but collectively we are known as the Rural Health Redesign Center. Again, advancing, ensuring access to high-quality healthcare remains in the state of Pennsylvania, as well as expanding that mission beyond the state of Pennsylvania. We move on to the next slide. So really then talking about, so that's the Pennsylvania Rural Health Model, our governing entity, and then similarly comparing this to then the AHEAD program. And so again, it's a state program. It's a 10-year program where ours was 1 year pre-implementation with 6 years of program. The AHEAD program is a 10-year program. There's state total cost of care targets where ours was really, our total cost of care was specific to our participant communities. This is really driving towards more of a state total cost of care view. All states are eligible. Ours was specific, an opportunity for Pennsylvania. This is opened up to all states, I think with up to 8 or 10 states to be selected for participation. I don't remember that number exactly, so don't quote me on that, but certainly there's a defined number of states. All states can apply, but a certain number of states will be selected. And there's obviously a cooperative agreement with funding, as has been published by CMMI. Program goals, again, through state and regional transformation and multi-payer alignment, really looking to improve the health of rural and state populations, but strengthen primary care and lower costs. So certainly the program goals are a little bit different than what we had identified specifically in the state of Pennsylvania. It provides states with funding to basically manage quality across all payers, really looking for that all payer participation, ensuring providers deliver high quality care, improving the health of populations, and really looking to advance health equity and care coordination efforts within a cost containment perspective. As mentioned, our program was one of 3 programs that actually informed the development of AHEAD. Obviously, the Vermont all-payer ACO framework informed the Maryland total cost of care model, informed AHEAD, as well as the Pennsylvania rural health model. So if we move on, we're going to get in a little bit more detail specific to the program comparison. And again, there's a lot of information on these slides. My goal is to hit the high points, not certainly talk through every bullet point on these pages, but really provide just a reference point if you're wondering how this compares or how this differs, to give that tool to the public and to the general community. So if we move on to the next slide, really at the highest level, looking at program goals. So what are the programs trying to achieve? And again, I've already hit on a little bit of this as I talked through some of those early slides, those framing slides, but really just wanted to put together a side-by-side comparison to understand the goals of our program versus the goals of AHEAD, where they're similar and then where they're different. So obviously, improving the health of populations covered within the program is obviously a common goal. Our program was specifically designed to improve the health of rural beneficiaries, and certainly the head is just to improve the population of all participant communities, which is beyond rural. It's urban, suburban, and rural. Obviously, the second goal is to maintain access to healthcare. In our program, it's really to rural populations by improving the financial viability of rural hospitals. So one of the primary goals we were trying to achieve is if we fundamentally change how hospitals are paid, can we actually improve their financial viability in the long term? Certainly, going across the page, the second bullet point in the head is really about advancing health equity. And then, the third in ours was to really determine the impact of an alternative payment on rural providers. And then, the third comparative within a head is, curbing healthcare cost growth and reduce expenditures for Medicare and Medicaid. So at the highest level, I would say the difference is ours was very much rural. AHEAD is not necessarily rural. Certainly looking to improve the population health of all members served within these programs. But really, I would say the defining difference is, ours was specific to rural, AHEAD is not, and we were really looking to test improved financial viability of rural hospitals through alternative payment and understanding what works and what doesn't work within alternative frameworks for rural providers specifically. If we move on to the next slide. So again, just, similarities between the programs. PARHM was a 7-year program. AHEAD is a 10-year program. Cooperative agreements, both, within both structures. Even though ours was voluntary and very rural specific, it still was considered a state-based model, as all rural populations across the Commonwealth, as defined by a very specific state, Pennsylvania state-based definition. All rural providers that met that definition were eligible to apply. But again, still considered a state-based model. And then multiple hospital participation based on PA-specific county definition, as I've already mentioned. And then within the AHEAD, multiple hospital participation for urban, suburban, and rural. So again, similarities, but also some differences. If we move on to the next slide. Again, some more similarities between the programs. So obviously both have global budget frameworks. So our program was a global budget, hospital global budget program specifically, really designed to stabilize the hospital. Certainly that has been a criticism, and I like to say whenever I speak publicly about our program, we know it wasn't perfect. There are lots of stones that could be thrown at it, improvements that need to be made to it, but certainly, again, provided a robust learning laboratory for us to determine what worked and what didn't work. So obviously that is translating into AHEAD. There is a global budget framework to provide for predictable payments to hospitals. Again, it's not on the slide, but ours was specific to hospitals obviously within the AHEAD framework. It's alignment with other types of payments, specifically primary care, and really looking to advance the primary care aspects within the AHEAD program. Moving on to the next, I would say bullet points. Can we
Sorry.
go back in this?
Yep.
Transformation planning, obviously that language is in both the PARHM program and the AHEAD program. I think probably the specific difference that I see as again, just looking at the NOFO, I don't have any inside, information beyond what has been made public, but just reading that NOFO and interpreting it in comparison to our program. The transformation planning concept is there. Ours was done at a hospital and community level. Really what I see in the AHEAD program is more aligning with state-based strategies and state-level transformation plans versus that individual community hospital. Within our program, there were hospital scale targets, and in the AHEAD program, there's beneficiary lives, and I'll get into a little bit more detail in the next slide specific to those 2 points. And then within PARHM, Medicaid participation was encouraged. We were fortunate enough to be able to recruit the majority of the Medicaid payers. In the state of Pennsylvania, Medicaid is managed through MCOs. We were able to recruit a predominance of those payers into our program. We were fortunate to be able to do that. But while Medicaid participation was encouraged within PARHM, it's required within AHEAD, recognizing the significant dollars that are flowing through the Medicaid program, really understanding the need for that to be included. I think we helped inform that, and certainly by us having our payers at the table, our Medicaid payers, it helped us to reach scale specific to the global budget that was covered within the program. If we move on to the next slide. Again, some more similarities. Commercial payer participation was required in our program. One of our things that we were aiming for was a payer scale to get a predominant amount of payment covered in the hospital global budget. So it really truly did allow hospitals to move forward with value and not necessarily have to worry so much about volume. As you can see in the AHEAD program, commercial payer participation is also required. There are certainly savings, the ability to achieve savings within the program. While we had total cost of care guardrails, our primary mechanism to achieve savings was really through methodology development, specifically addressing avoidable utilization, and how we were going to achieve savings through avoidable utilization. So we had total cost of care guardrails, and savings really through methodology development, specifically geared towards potentially avoidable utilization and basically right care, right place, and reducing utilization that didn't necessarily need the care didn't need to be provided in the hospital. AHEAD, there's savings really achieved through total cost of care targets, both at the program and the hospital level. So if you read through the NOFO, there's a lot of metrics in there in terms of how savings will be achieved and metrics will be established. Obviously, another similarity is the model governance requirement. We had that written into our program. We were basically required to create the Rural Health Redesign Center as a key foundational element of our program. We do see similar language in the AHEAD, certainly not mandatory, but stakeholder engagement, public representation. So again, while not identical, I think the concepts for a shared governance of stakeholders is what I see within the AHEAD language, and how states choose to get there. There is some flexibility within the AHEAD program of how folks can get to that shared governance. So we clearly can see as we look at the AHEAD NOFO, and again, we'll get into a little bit even more granular detail in the forthcoming slides, but we certainly can see where our lessons learned from the Pennsylvania Rural Health Model experience have definitely informed the AHEAD program. If we move on to the next slide. So just highlighting that point a little bit, pulling some of that out where, in addition to what I've already shared, where we can see, I think, learning from our program as it relates to creating that robust learning laboratory, the extension of the timeline. So, this is really, really hard work. If it wasn't, it would have already been done. And so the fact that, improving population health It's my opinion that a lot of the cream is gone in this space through readmission reduction programs and some of the other quality programs that have been in this space for a while. And so in order to really make meaningful change and really be able to, I would say, approach this from a systematic or systemic viewpoint takes time. And so with the expansion, to a 10-year program, throughout the years since we've been administrating this program, we've had a lot of conversations with CMMI, weekly conversations, and really identifying that, for meaningful change to happen, we need longer runways. And so the fact that this is a 10-year program, we can see where we think our experience, as well as some of the experiences of the other states, have informed that. Multiple hospital participation for urban, suburban, and rural. I think one of the things that we've, recognized, through our program is the ability to achieve savings in rural communities is really, really tough for a lot of reasons. There's some underinvestment, being made there, as well as infrastructure needs and all of that. But I think one of the other things that we helped inform was what's an appropriate scale. So our original scale was to try to get 30 hospitals to the table. As I look from a change management theory perspective, to get 30 hospitals to the table out of a denominator of, I think it was 67, that's almost 50%. We were expecting 50% of our rural populations to be early adopters. And anybody that knows anything about change management, you rarely get 50% of a population to actually be early innovators or change adopters. It's a fraction of that. And so while we didn't reach our scale of 30, we considered the 18 highly successful, again, because these are early adopters, early innovators of change. And so from a change management perspective, we've actually exceeded that threshold. So while we didn't meet 30, we still found 18 wildly successful simply because of the early adoption of change. The other thing, though, while we didn't reach 30, we actually had sizable scale from a Medicare beneficiary perspective. And so the Medicare beneficiary number goes up and down every year, depending on how many people choose Medicare Advantage. We do have a high prevalence of Medicare Advantage in the state of Pennsylvania, but thankfully, our Medicare Advantage payers have been at the table with us, the majority of them. But what we have been able to achieve is a scale of Medicare beneficiaries of around 120,000. So within those 18 communities, we do have sizable scale. So, while a head's Medicare minimum is 10,000, just from a reference perspective, we currently have about 120. And again, that number goes up and down, determined upon how beneficiaries choose to get their coverage, either through traditional Medicare or the Medicare Advantage. But again, we find that wildly successful. It has a minimum of 10,000. We currently have 120,000. So again, seeing that change from a set number of participants to a beneficiary count, we actually see that as a lessons learned from us, that there might be a better way to actually measure or scale these and look at a beneficiary versus a set number of hospitals. Obviously, PARHM has demonstrated that the MCO, the managed care organizations, and commercial participation is really essential and required in order to be successful. You've got to have a predominance of that payment coming in through the alternative payment in order for hospitals to truly focus on changing their delivery system. And again, we feel like, our experience helped inform that. And then the last one is, the reduction in hospital spend at participant hospitals. So not total cost of care. We had a specific metric in our program about spend at participant hospitals. And I think one of the things that we learned is, especially in rural communities, there's a lot of bypass unless there's things happening at the state to regulate that. There's a lot of bypass, and the majority of hospital spend is actually happening at larger urban and suburban. And so while we, through the global budget, are trying to ensure our hospitals stay open to keep that access to basic healthcare in rural communities, in order to really, I would say, achieve savings, you need the urban and suburban. And so again, believe that our experience within Pennsylvania has led, to CMMI identifying the need to expand this to more urban and suburban. So while rural is eligible too, participate. It's not a rural program. And in order to, reap savings, you need those larger facilities because that's where the majority of the hospital spend is happening. If we move on to the next slide. So again, as I go through these next slides, it's going to be a little bit more granular detail. I'd encourage you to read the slides. I'm going to hit these at a really, really high level. There's a lot of information, but really just trying to give you, again, a sense of where our methodology that we developed, that we wrote, where we can see it as we read the NOFO. And again, I don't have any more inside information than anybody else. I'm reading the same NOFO, but when I see the language that's there, it provides a reference point for me as it relates to Pennsylvania, and just sharing that information with you. So if we move on to the next slide. Just at a high level, this is a slide right from CMMI's information. So just, putting it in here that there's different cohorts in terms of eligibility. There's different timelines of when you can apply, but certainly understanding the methodology and understanding the frameworks and how well you understand those frameworks will help you identify whether you want to be a cohort 1, cohort 2, or a cohort 3 hospital. So again, just sharing this information and understanding the methodology, which I believe is forthcoming. More insight from CMMI is coming next week. Will certainly help you identify, states that may be ready and states that might need a little bit more work based on their understanding of the methodology. So if we move on to the next slide. So again, these are just, my attempt to go through and break down the various components of the NOFO and provide a comparative between it and the Pennsylvania experience. Again, just from a knowledge and a learning perspective of where we might have insights that might prove valuable to states as they're sorting through this information. So the baseline calculation, both programs have a 3-year average. Obviously, the AHEAD program is using a weighting. Ours was a straight average. It was the greater of either the most current year or the preceding 3-year average. My comment to this is, depending on the circumstances within the community and subsequent market shift methodology, this weighting could be viewed as favorable because it could help mitigate market shift calculations that could come later. But again, until we see the detail behind the methodology, that's uncertain, but certainly, this could prove beneficial. Again, dependent on the community and dependent on how much market shift you have happening in your geographies. This could be beneficial, but more information is needed to fully determine that. Mechanisms for savings. As I already mentioned, our savings mechanism was really driven through PAU, focusing on potentially avoidable utilization reduction. Early adopters of the methodology received more benefit than those folks that came to the table later. So similar to the AHEAD program, we had actually 4 years of onboarding because to remind everyone, we were launching and recruiting in the midst of the COVID pandemic. So we were originally to have 3 onboarding years. We actually tried to have a 4th, but very much that cohort experience, like you're seeing in the NOFO, we did our program through cohort types experience as well. Our program allowed more benefit for early adopters than for late adopters. So again, you can read my comments specific to positive, negative, but just providing that comparative. Ours was PAU. AHEAD is really about total cost of care and the calculations and the algorithms to identify those total cost of care metrics that you'll be held accountable to. Avoidable utilization adjustments, I've already hit on that a little bit. Certainly we had potentially avoidable utilization global budget adjustments. That was where the primary mechanism for shared savings between our participant payers and our participant hospitals. There is PAU methodology identified in the AHEAD NOFO, but it's really, again, to reduce potentially avoidable utilization, but it's called an effectiveness adjustment. So while ours was called avoidable utilization, this is translating to what is being called an effectiveness adjustment within the AHEAD NOFO. If we go into the next slide. Service line changes. So this was really, really important to our hospitals when we recruited them into the Pennsylvania Rural Health Model to understand that if they changed their service lines, how that was going to then translate into the global budgets. And so, again, similar language between the two programs, more information forthcoming from CMMI specific to the detail. But, this was very, very important again to our hospitals to understand that if I change my service line, either, to meet community need, and that can mean expansion of services or maybe even retraction of services, how is that going to impact my global budget? Because certainly, predictability of revenue and meeting the needs of the community is paramount. Moving on, population risk consideration. So this is one area that we did not have in Pennsylvania. From I would say, social determinants of health, risk adjustments, identifying the needs of the communities. We did not have that in ours. And so we actually see this as favorable, that this has been accounted for, that could allow enhancements to the global budget. So again, I'm anxious to see what this looks like because we did not have that in ours, but I do think that's a positive recognition, that if hospitals are going to be asked to step into this space, there has to be compensation for that work. Demographic adjustments, again, similar language between the two programs, detail more information forthcoming from CMMI. Inflationary adjustments, that language is similar across both programs. Market shift adjustments, we called that unplanned volume shift. And so you've got planned service lines, things that you plan to do, but at the end of the day, the community still has choice. And so in our program, it was really called unplanned volume shift. And so if community members chose to go somewhere else, and that was of significance that you could see it in the data, global budgets could go up or down based on how the community was reacting to the local hospital. And ahead, the methodology will include adjustments for material shifts in volume. So I'm anxious to see what the definition of material shifts in volume could mean. I will tell you in our program, this market shift has created the most volatility in our program. So dependent on how, the material shifts are calculated and the proposed, management of this, it actually could mitigate some of the volatility that we've experienced in our program. And so again, I'm anxious to see the changes and how we have informed that in order to have predictability, market shift adjustments might need to be minimized. But again, anxious to see the methodology. If we move on to the next slide. Health equity consideration. Again, here's another one where we didn't have anything in our program. And so, the language that's identified in the AHEAD NOFO is intriguing because, again, we do think if hospitals are being asked to step into this space, there has to be some recognition of the cost that goes with that. But again, while seen as a positive change, data collection is the one thing that was identified within the NOFO that's delaying it. And again, understanding the potential administrative burden that might come with these types of additions, especially for small, in particular rural hospitals. If they're considering this, it's important to understand the resource that might be needed to help maintain this. Quality programs, similar language between the two programs. Again, transformation consideration. So when we say consideration, we mean money, extra money for hospitals to invest in transformation. That has been a big criticism of our program, as we're asking hospitals to step into the transformation space without any recognition of upfront funding in order to actually do some of that work, instead of thinking the global budget was going to meet all of that need. And so we didn't have any consideration for that in our program. And so again, please see this as a favorable change, that there is a recognition for at least some funding. Whether it's going to be enough funding, I think that's the question. As I've engaged with some rural hospital leaders, will it be enough is the question. But again, it's viewed favorable by us. And just to note, there is a risk of repayment should a hospital exit the program. So if if they got transformation planning and decided a couple years down the road, it's not worth it, this is not working for us, there will be a path out, but this would be one area of potential payback. Exogenous factor language, we sure were thankful that we had this in our program because the pandemic hit. In our performance year 2. And so as the RHRCA board, we spent a lot of time working through exogenous factor adjustments. We were thankful that was in our program. I did not see that directly identified in the NOFO. Perhaps I missed it, but just identifying that there has to be some amount of exception based in the event of a mechanism that should another pandemic hit, that there's assurances that that will be managed effectively through the methodology. And again, that just ties to the next bullet point, exceptions based. We did have language, in our review process that we can call for reviews of the budgets, both by hospitals or payers, dependent upon the need. And we see that same language in the AHEAD NOFO. Hospitals may request exception-based adjustments subject to CMS approval. If we move to the next slide. Want to spend a little bit of time talking about critical access hospital methodology specifically, because while our was a rural specific program, we did not interrupt the cost-based reimbursement for critical access hospitals. And so as you look at the AHEAD NOFO, while broader populations are eligible to apply for this, there is some specific, I would say, methodology in there for critical access hospitals. And it's interesting as I talk with folks considering this, at the surface, a lot of hospitals, especially critical access hospital leaders, see this as a risk. And I want to just say I'm encouraging folks to think about this and be open-minded, that as I've worked with critical access hospitals, I was a former critical access hospital leader. And as we move into the value-based work, as long as you're cost-based reimbursed, it's really hard to grow a margin. Again, a lot of this comes back to your payer mix. How much Medicare Advantage do you have? How much traditional Medicare do you have? Seeking services at your hospital. But one of the things that I suggested to, our CMMI colleagues was, can we identify a way to maybe test a new mousetrap within a safe space for the critical access hospital? So seeing this language, I do feel like we've informed this to allow hospitals that might be at the table in this framework and a critical access hospital to try something different, recognizing that, more than likely, again, this will be detailed in the contract itself, but more than likely there will be a path back if it's not working. But really allowing hospitals the ability to test, can we actually grow margin as a critical access hospital through population health and quality? Because of the critical access framework, even if you are successful, at the end of the day, you come back to cost. And so your ability to grow margin is limited. So again, devils will be in the detail, but I think this is a favorable concept. I think my concern with it overall is really about the definition of fixed cost. We also proposed a floor, some type of a budgetary floor for the critical access hospital. The NOFO identifies that going back to cost report, fixed costs, and certainly concerns for rural hospitals in particular. A lot of your staffing costs are fixed or semi-fixed versus variable. Critical access hospital transfer, CAH transformation consideration. Again, holistically within our program, there really was no consideration or funding for the critical access hospital to transform. So again, do view this as favorable, that there is some incentive there for the hospital, some investment for the hospital to actually begin that transformation journey. And so again, feel like we informed that through some of the struggles of our program. We actually helped inform that for that enhancement. A critical access hospital quality adjustment, again, no consideration in our program. So the fact that, critical access hospitals will be eligible for an upside quality program, we do view that again as favorable, feeling like we have helped inform some of that. But again, understanding that critical access hospitals have not historically been required to provide this level of reporting, really understanding the reporting mechanisms and the burden would be something for consideration. If we move on to the next slide. Total cost of care, again, critical access hospitals, total cost of care, because at the end of the day, everything came back to cost. It's, it's hard to manage total cost of care when you come back to cost and are paid costs. So there was no consideration in our program. Again, within AHEAD, the total cost of care performance adjustment will begin, upward only during PY4 and PY5 based on performance years 2 and 3s. So that's one of the things that unfortunately has not been able to be cracked is there's always a data delay. Which makes programs of this challenging because the data by which to measure performance is always at a lag. But again, my caution here is, since this information is not currently published for critical access hospitals, it's really hard to know. Some folks voluntarily report, and for those that voluntarily report, you'll have this information. But for those that don't, it's going to be hard to maybe assess where you're starting from a quality perspective. And while there's runway for improvement, if hospitals are already performing well, so say you're already an early adopter, you're doing really, really well, you could potentially be limited on your improvement because, the work gets harder as you go. So if the cream is gone, you've already done a lot of work. This could present a challenge to you in terms of reaping the benefits of that. So just something to consider. And then avoidable utilization adjustment. For the critical access hospital, again, as I've already mentioned, there's really no adjustment for it because at the end of the day, if you reduce readmissions or reduce ED utilization, that comes back from a cost report perspective, and your costs are based on that utilization. And so you can never get any better than cost. And so we really didn't have a mechanism in our program for, like I said, a critical access hospital to grow its margin for the Medicare fee-for-service, traditional Medicare fee-for-service book of business. We did have that for Medicare Advantage because, a different program dictated that. So again, the effectiveness adjustment is applicable to the critical access hospital, beginning in PY3 or within AHEAD. So again, we do view that as favorable with the ability for hospitals hopefully to begin to grow a margin within a safe space. If we go on to the next slide. Just a few other things as it relates to methodology, different adjustments. I'm not going to read through this, but then just making a note on as it relates to the model governance as well as the TA funding. So if you look at the NOFO, it specifically says technical assistance funding will be available for critical access hospitals that participate. Our program, funded TA for all program participants, but, the NOFO specifically said for AHEAD that it was for critical access hospitals. And so again, just showing that to you. And then model governance, there is a requirement to have a formal model governance structure within the AHEAD program. But as I stated earlier, there seems to be a lot of flexibility within that space. But again, we do believe that our creation of the RHRCA actually helped inform the need for some type of a governance structure with stakeholder input. So I think with that comes to the end of my formal content. Oh, no, one more. Sorry, probably one of the most important slides. So we are being very transparent with the fact that, in the state of Pennsylvania, we are not planning on advancing and submitting an application for the AHEAD model as part of cohort 1. And the reasons behind that, as I went through this, you can obviously see that I do think there has been favorable changes to the methodology. Again, we've informed it. We've provided robust learning ground. We've provided, thoughts and inputs as it related to a next generation Pennsylvania strategy. And we see some of those recommendations flowing through, with what has been published in the AHEAD NOFO. But at the highest level, we do not feel like the AHEAD value proposition actually aligns with what we're trying to do in the state of Pennsylvania, which remains preserve access to rural health care. And AHEAD is really more about producing Medicare savings. So we agree on population health improvement, but as it relates to the primary mission of, ensuring access to care versus achieving savings, we just do not believe at this point the AHEAD program is going to allow us that path. So, just to highlight the point in red, the work of the Pennsylvania Rural Health Model, identified that these goals really cannot exist given the historical underinvestment in rural healthcare, and that actually more investment is needed in rural communities to improve population health outcomes. So thinking about a rural-only program within a HED, the ability to achieve savings is really limited. And as a result, we are not confident with moving forward with an application at this point in time. So now I think I've come to the end of my standard content and really do just want to address some of the questions that came in through the registration, as well if there's any questions that have come in through the chat, or if the community on the line has any questions. So Candace, I'll turn it back to you.
Yeah, Janice, thank you so much. And thanks for sharing this incredible wealth of knowledge that you've been collecting over the past several years, and putting that as a comparison to the models. I'm going to read to you some of the questions that we got in through registration. Again, just encourage you, if you have any questions, please submit those in the Q&A. You should see that at the top of your screen. So feel free to type those in while I'm talking. One question that came in related to PARHM and the chart models. Can you speak a little bit about what the recruitment goals were, and was there enough participants to be successful? I think you kind of hit on this, but maybe just home in on that a little bit more.
Sure. So certainly, as I mentioned earlier, at the surface, it doesn't look like we hit our recruitment goals, 18 versus 30. Chart was, 10,000. I think charts, and again, this is my opinion only. I think there were other things from a policy perspective that made chart not be successful from a rural health policy perspective. The global budget methodology within chart that actually caused it to not be successful versus the recruitment targets of 10,000. So I think it was more the policy design than the scale target that resulted in chart not being successful. As I already mentioned, within those 18 participant hospitals, we have, roughly 120,000 Medicare lives. And so we count that a huge success when we see now requirements of 10,000. The fact that we have 120 tells us that we really did reach sizable scale within our program.
Excellent. Thank you. So a little bit of a longer question related to services provided in the home. Can you talk a little bit about what PARHM may have learned through home care? How are we helping to improve care in the home, perhaps address patient adherence, addressing reducing avoidable admissions, and some ways to expand and use partners to support post-acute providers?
Yeah, so I'm certainly not going to say we cracked that nut and we've solved that problem, but certainly through our transformation plan, our hospitals were encouraged to engage with community providers, including nursing homes. From an in-home care perspective, we think that's a huge area of opportunity in terms of next generation through concepts such as mobile integrated health. Taking ET3 concepts and how do you reuse or redeploy clinicians in these rural communities that might be able to actually expand in-home care. So we've had those conversations within our planning, within our summits that we hold, really identifying, I would say, future strategies of how to enhance in-home care. Especially again for rural communities, how do we redeploy, knowing some of the barriers that exist from transportation and all of that, and is there ability to rethink how we can use trained clinicians? One area where we have made significant progress, and again, it comes down to the transformation plans at the local level, some of which we're looking to identify and then translate across our program wherever possible, but really using technology within nursing homes to really identify those patients and keep them in the nursing home through technology versus having them loaded into an ambulance and presenting at the emergency room for non-emergent care. care. And so really working with nursing homes to engage them on the transformation journey, as well as all other. One of the things we ask our hospitals to do as part of the transformation plan is put together a stakeholder engagement strategy. We ask them every year to identify who the community stakeholders are. And that could be primary care that's not employed by the community. It could be office of aging. It could be nursing homes. But as part of that transformation plan, we actually ask them to identify their community stakeholder engagement, who they're going to talk with or who they're going to reach out to. What does the partnership look like? What do the communication channels look like, really to advance this at a community level?
Excellent. One last question related to global budgets. For hospitals that are also in programs like Medicare or Shared Savings Program, how are savings accounted for?
Yeah, so our contract, our agreement as written is, hospitals can participate in multiple programs, but we do have to protect against duplicative savings. And so we have a process that we've worked out with CMMI, especially specific to the MSSP program, where, they run reports on their end, and then we validate, because we also know, again, our program is hospital specific. Sometimes hospitals are part of the ACOs, that MSSP framework, and sometimes they're not. And so identified, how much of a shared savings actually came back to the hospital in relation to the investment that maybe the hospital had to make to participate in that MSSP. And so we have a reconciliation process. It's done, again, a retrospective review of, okay, this is what a hospital shows that they may have received through an MSSP program, and then to make sure that it's not duplicative in the global budget framework. There's just, I would say, a retrospective review process that we do in cooperation with CMMI.
Excellent. Janice, one other question. This one sort of came through on a chat, and maybe there was a little bit of lack of clarity on the 10,000 requirement for 10,000 lives. Can you just talk a little bit more about that, just so everyone's clear about what that really means?
Yeah, so specific to the AHEAD, and again, I would encourage you to listen to the CMMI listening sessions and all of that. But my understanding is that in order to put forth an application for AHEAD, you have to have at least 10,000 covered lives within that application. And so again, there's more than just the 10,000 covered lives that is going to be looked at to deem if that application is successful. Total cost of care savings targets and all of that, but you have to have at least that minimum in order within your participant communities in order to submit an application. And so really identifying that scale is my understanding of kind of the, you have to have that as a qualifying in terms of how you're going to reach that.
Thank you. One other question that came in related to the slides, and I think I already addressed this, but I'll say this again. We will have the slides and recording available on our website at rhrco.org. So I encourage you to go there to pick up the slides. Again, we are going to be, this is part one. So Janice, thank you for taking us through sort of a comparative. For those of you who may not have registered for the second session, you're welcome to do so. You should be able to click on your screen to register if you haven't already done so. You can also find a link to our second session, which will be in 2 weeks on February 21st at 1 p.m. Eastern. Would love to hear back from you, or would love to have you return so we can talk through with you on the lessons learned from the Pennsylvania implementation experience, sort of delving in a little bit more there. Here's our contact information again, sort of gave it to you at the beginning, but here it is for you again. If you're not already following us on social media, I encourage you to do so. We routinely push out information that's relevant to rural communities and would love to be able to share that with you. So I encourage you to follow us on social media. I'm also going to be dropping into the chat a survey link. I would ask that if you could please take a moment to fill out a survey, let us know how we did, if there's anything else that we can do to answer questions that you might have. I will also be sending out an email to all of you who attended today's event with the same survey link. So look for that as well. Janice, any other closing thoughts before we close out today?
No, just thank you for joining us and reach out if you have questions.
Excellent. And Janice, thank you so much for sharing your knowledge with us. We look forward to seeing you all in 2 weeks. Thank you, everyone.